Hey, thank you for joining me for this lecture. The assigned topic for this lecture, the official topic, is what's on the screen. It reads aspects of quantitative and semi-quantitative TEE and diastology, which almost encompasses everything there is to know. So I am going to narrow our focus a little bit and say that we're going to talk about LV quantification and how to quantify systolic and diastolic function. This used to be 2 lectures, one on LV quantification alone, so I'll go into it briefly, mainly so that you can decipher the LV part of an echo report. So you might see something like this, commenting on the size of the ventricle and the wall thickness. And as far as quantifying the LV chamber goes, there are 4 main parameters here. So we'll do a brief introduction for each. And they are the LV wall thickness, the internal dimensions, LV mass, and volumetric parameters. For LV wall thickness, when you're assessing it visually, you can see here, for instance, a normal looking LV with normal wall thickness. And that's this one over here. And then you see one that's definitely a little bit thicker on the walls with LV hypertrophy, such as in patients with aortic stenosis or long-standing hypertension. This is not the same as a dilated ventricle that's enlarged, as seen on the right, where the chamber itself, the size of the chamber, is enlarged. LV wall thickness is measured by M mode or in 2D in the parasternal long axis view for TTE or in transgastric mid-short axis view for TEE. The ASE recommends measuring 2 walls, the septal and the posterior walls at end diastole, and to ensure that you're not including any papillary muscles in the assessment. There are normal and abnormal values for both males and females, and this you can always look it up online. I use a roughly 1.0 centimeter cutoff rule as a rule of thumb for what's looking abnormal, and then look it up on a day-to-day basis for what is mild, moderate, or severe. Next to it, the internal dimensions of the LV, and these measure whether a chamber is dilated or not. It is generally obtained in the mid-esophageal or transgastric 2-chamber views, and you're after the maximum obtainable diameters in diastole while ensuring that there is no foreshortening. And again, there are normal values, and the tables of the normal value tables can be looked up easily online. And the values do differ for males, females, and also by BSA. So you can index that to a person's body surface area, especially if you have somebody who is extremely small or large. LV mass can also be used to estimate whether you have a hypertrophied ventricle, and the measurements here you need that you get from before can be plugged into this equation. And there are, of course, normal values as well. Once again, you can index this to BSA. And we won't go into a whole lot of detail here. It's mostly to point out that this exists. And let's talk about the right ventricle quickly. Normal values for the right ventricle, unlike for the left, are not currently indexed to BSA. In general, most people think of a diameter of greater than 4 centimeters at the base to be the cutoff for a dilated RV. But you can see how it might be difficult to apply one cutoff to across all different patients. But these are the different internal dimensions that are typically measured when trying to quantify RV size. And here are the normal RV values. For illustration, and there's mild, moderate, and severe. And there's the one at the base, mid, and the base to apex length. As a general rule of thumb, the RV should not appear larger than the LV, and its apex should not reach beyond that of the LV apex. So this here is a normal looking RV, and this here is an RV that's clearly enlarged because the apex is matching up with the LV apex, and the chamber itself is also almost the same size. You have to be careful, however, when getting a picture like this one, that you just don't have a foreshortened LV. Moving on to LV systolic function, you might see this written on the patient's echo report. There is a qualitative and a quantitative comment here that systolic function is moderately reduced, and ejection fraction is about 35%. So let's chat about what that means. The ways to quantify LV systolic function are: you can do a visual estimate, also known as the calibrated eyeball, or you can use one of these methods: fractional shortening, fractional area of change, which you're probably, or the ejection fraction, which is what you are probably most familiar with. Respectively, this is a one-dimensional tool, a two-dimensional tool, and a 3D estimate. Starting with the calibrated eyeball or visual estimate, you can see here what a hyperdynamic ventricle looks like, what a relatively normal ventricle looks like. So this one's a little hyperdynamic. This one has severely reduced systolic function, and the one in the middle is what looks like a relatively normal EF. And from left to right here, in more of an apical 4 view, you can also tell that there are increasing degrees of LV systolic dysfunction here. And you do this is a visual estimate that the pictures provide you with. So really, using one of these quantitative methods that we're going to talk about next and correlating that with what you're visually estimating is the best way of calibrating your eyeball. So let's start with fractional shortening. So fractional shortening is a one-dimensional method of estimating LV systolic function. Placing the M mode through the parasternal long axis view will give you this picture where you can measure LV diameter in systole and diastole as it contracts and relaxes. And when you subtract the difference between what's here in diastole and here in systole and make that a percentage of the LV diameter in diastole, then you'll get fractional shortening. A normal fractional shortening is greater than 25%. From fractional shortening, another parameter can be calculated called the velocity of circumferential fiber shortening. And that is the fractional shortening multiplied by the ejection time, and normal is greater than 1.1 circumferences per second. When 2D images became available, the area of the LV cross-section could now be used as a measure for LV systolic function. The idea is the same. Find the difference in systole and diastole, express that as a percentage of end diastolic area, and you get a fractional area of change. A normal value in this case is greater than 40%, which corresponds to about a 55% ejection fraction. And this here is pretty much what we're doing when we're trying to calibrate our eyeballs to the transgastric mid-papillary view. So greater 40% in this case is what corresponds to a normal EF. The ejection fraction is a measurement of volume. How much volume is ejected? Calculating this assumes you have information about 3 dimensions of the heart and not just an area. It can be calculated by Simpson's method of disc, an area length method using this equation, or by obtaining a 3-dimensional data set to derive a 3D EF. Here's what performing a Simpsons looks like. Using a series of discs traced to the outline of the left ventricle in the 4-chamber and 2-chamber view, the computer tries to approximate the volume of the LV in systole and then in diastole, and it subtracts the two to get a fraction that is ejected. In a 3D dataset, the computer stitches together a series of 2D images to create a full volume dataset. And from this, you get the difference in volume in systole and in diastole. Note that if you were trying to measure contractility, there are other methods such as isovolumetric indicators, like the change in pressure over change in time, and tissue Doppler or speckle tracking with strain technology that can also give an idea for whether myocardial contractility is normal. Using echocardiography, you can also estimate a stroke volume by obtaining a cross-sectional area of the LVOT and then using pulse wave Doppler to measure the velocity time integral across it. And this first requires knowing the LVOT diameter, then obtaining the pulse wave Doppler through the LVOT in TE that's usually obtained from the deep transgastric view, and then tracing this gives you the velocity time integral. So a normal stroke volume is about 70 cc's for a 70 kilogram adult. And this page here summarizes the ways that you can obtain a quantitative estimate of LV systolic function. You see of note here that as the number of dimensions you're using for information goes up, the normal values also go up. So a normal EF is one that is greater than 55%. Moving on, we'll cover left ventricular diastolic function. Let's pause for a moment to talk about diastolic heart failure. So in patients with diastolic dysfunction, but not heart failure, they have an inability to fill at low pressures and are usually asymptomatic. When diastolic heart failure sets in, you have decreased cardiac output as well, and patients are often have the classic symptoms of heart failure, like dyspnea on exertion or when they're laying supine. So diastolic heart failure, as we all know now, is not the same as systolic heart failure. So diastolic heart failure patients can have near normal LVEFs and LV and diastolic volumes, especially if they're early in the stages of diastolic dysfunction. And patients on the flip side with systolic heart failure, they often have some amount of associated diastolic dysfunction as well. When you have diastolic heart failure, this is when you get elevated BNP. You also get elevated circulating catecholamines. I know it sounds like I'm stating the obvious when I say that diastole occurs when the ventricles are filling and not contracting. But looking at this graphic, just make sure that you can hit pause in your mind for when diastole is. And let's go on to consider. So while systole has 2 phases, diastole has 4. So let's break that down a little bit. Diastole starts when the aortic valves close and you start having the contraction of the LV, and it is isovolumetric until the mitral valve opens. And when that happens, there is a rapid early diastolic filling, followed by a period of diastasis, and then followed by atrial filling when the atria contract. Diastolic heart failure happens when there's increased cardiac filling pressures because of impaired LV relaxation, reduced restoring forces, and early diastolic suction, and when the LV chamber is increasingly stiff. Why does diastolic function matter? So, in a sequence of what happens during coronary ischemia, first you get a maldistribution of flow and hypoperfusion of the coronary arteries and hypoperfusion of the myocardium. Diastolic dysfunction is actually detected first before systolic function is detected on echo, and before you see any EKG changes, and before a patient gets any form of chest pain. So diastolic dysfunction is actually an earlier marker of ischemia than all these other things that we typically look out for. So in the perioperative setting, the significance of diastolic function is that 60% of surgical patients greater than 65-year-old with normal LVEFs were found in one study to have diastolic filling abnormalities, and this was associated with having more arrhythmias, tachycardia, myocardial ischemia, fluid shifts, and myocardial edema. 50% of heart failure cases are isolated diastolic heart failure cases with normal systolic function. And like we talked about earlier, in coronary ligation studies, folks found that diastolic function is affected way before you see wall motion abnormalities or ST changes. Diastolic function is also found to be an independent predictor of mortality, so a threefold increase of death if there is restrictive diastolic function found after having an MI. And the progression of diastolic dysfunction is also associated with mortality. This, for instance, is a survival curve from one study that looked at event-free survival after an MI in patients who had restrictive filling, which is a type 4 or grade 4 diastolic dysfunction, versus those who did not, and they had clearly much lower survival over 4 years of follow-up. It's interesting that diastolic dysfunction is not evaluated more often because there is no eyeball test, unlike for systolic function. It relies heavily on a lot of Doppler interrogation techniques, and there's no one single test to identify and classify it. And at this point in time, there are no clear therapeutic options. So we talked about the phases of the cardiac cycle. Keep this in mind, that there are 4 phases of diastole: the isovolumetric relaxation, early diastolic filling, diastasis, and atrial filling. And see if you can identify all 4 phases here. First, we have isovolumetric contraction. Then the mitral valve opens and there's early filling. And then there's a period of diastasis here. And then there's an atrial kick and atrial filling. And I'll let this play one more time if you're unconvinced, to see if that helps. All right. So what this corresponds to when you do a pulse wave through the mitral valve is you get that early filling right here when the mitral valve opens. Then you get a period of diastasis, and then the atrial contract. And I can't keep up with the dots, and then you get an A wave. So that first E wave is an early filling wave. When the mitral valve first opens, there's diastasis that occurs here, and then the atrial contract. So the initial early filling depends on ventricular relaxation, which is an active process that requires ATP. for the ventricle to relax after the actin and myosin filaments have overlapped. And this happens earlier. This is in contrast to the late process where the ventricle has to accept what is coming in from the atria when they contract. And this is the ventricular compliance. It is a passive process. So the ventricles are already in a state of relaxation. They have filled, and how compliant they are is one of the factors in how much more volume comes in during atrial systole. There are 4 main Doppler assessment methods that have been described for assessing diastolic function. These are the transmitral inflow velocity, which we touched on a little bit earlier, the pulmonary venous flow, tissue Doppler imaging, and color and mode flow, which the ASE does say has lower reproducibility and reliability. But we'll go over it just for the pictures. So transmitral inflow is when you place a Doppler, like we said earlier, right at the tips of the mitral valve. And as you see, you get that early filling of an E wave, a period of diastasis, and then an A wave during atrial systole. Using this Doppler, you can get a slope, a deceleration slope as well, over here. And you can get the ratio of the mitral valve, E to A wave. In a normal patient, the E wave is larger than the A wave because most of the filling occurs during that early relaxation phase when the ventricle is empty, the mitral valve opens, and you get that suction force in. Then when you have grade 1, 2, and 3 diastolic dysfunction, you get these progressive changes illustrated here. First, you get abnormal relaxation. So that suction force is not as great. So when the mitral valves open, the E wave is blunted, and you get a relative reliance on the amount of atrial kick that you get. This is when you hear people say this patient's going to really need their atrial kick. That's because the A wave contributes more to ventricular filling than in a normal patient. In this patient, the LA pressure is somewhat increased. Now, over time, as LA pressure increases even more, then you get a pseudo-normalization of the waveform because the pressure is high and you get an E wave that again looks higher than the A wave because atrial systole doesn't contribute to filling as much anymore. And as LA pressures increase even more, then ventricular dysfunction becomes even more pronounced. You get a very sharp early filling. It also terminates very quickly because this ventricle is now very stiff. You have a longer period of diastasis, and then you get a very small amount of contribution from atrial systole because the ventricle is unable to, the compliance is also low, and it's unable to get any last bit of filling from atrial systole. The pulmonary venous flow illustrates the same story. But normally, systolic pulmonary venous flow is higher, and in diastole it's a little bit lower, but it is all forward flow. Sometimes you can discern an S1 and an S2. It's really important to have EKG so you know where diastole is here. And so normal, like we said, has an S that is greater than D. In grade 1 diastolic dysfunction or impaired relaxation, it will still look relatively normal. However, if you have grade 2 diastolic dysfunction, the S wave will be blunted and the D wave will be greater than the than the D wave. So S will be less than D here. And this is the same in restrictive disease as well, or grade 3 diastolic dysfunction. There are some limitations to the use of those two methods in that they are age-dependent and load-dependent changes, unfortunately. Tissue Doppler imaging is a little bit less load-dependent, and what it is if you send a tissue Doppler signal through the lateral mitral wall annulus wall, then you get an opposite of the ENA wave because the deflection is upwards as the ventricle fills. This lateral wall, this point on the lateral wall is going to move up. So during early filling, you get E prime, and during atrial systole, you get an A prime. And normally, E prime is greater than the A prime, just as we talked about. A normal value for E prime is greater than 10 in general, as a rule of thumb. 10 centimeters per second. Color M mode using propagation velocity is where you place color Doppler over the mitral inflow and then M mode through that to obtain a picture that's like this. It's very colorful. And then you get the slope of this inflow, and that's called the propagation velocity. And a number greater than 50 centimeters per second is what is considered normal. However, the disadvantages are that you cannot really classify the severity of diastolic dysfunction. You can only identify whether or not there is diastolic dysfunction present. This is a summary of the 4 different indices that we talked about and what they would look like in a normal patient and somebody with grade 1, 2, and 3 diastolic dysfunction, also known as impaired relaxation, pseudonormal, and restrictive diastolic dysfunction. These are the ASE guidelines for how to evaluate LV diastolic dysfunction by echocardiography. You can see that there's not it's not a very simple algorithm, clearly, and this is in patients with a normal EF. So it probably wouldn't surprise you when a study finds that at least 33% of echocardiographers call diastolic dysfunction indeterminate. When it comes to the perioperative assessment of diastolic dysfunction, some years ago, a group of authors proposed a simplified algorithm using only 2 measurements, which is the lateral wall early diastolic velocity, the E prime, and the early phase E wave from the transmitral inflow. And they found that it was a lot easier than this algorithm from the ASE that we talked about. So we had only looked at the normal LVEF. This on the right here is for patients who do not have a normal LVEF. So this algorithm says that if your lateral E prime is greater than 10 centimeters per second, it's usually somebody with normal function. And if it's less than that, then E to E prime ratio will help you distinguish between grade 1, 2, and 3 diastolic dysfunction here. And they found that using that algorithm, it corresponded to the prediction of major adverse cardiac events such as MI, revascularization, and death after patients who have had CABGs. So the bottom line for diastolic function is that it is an early indicator of ischemia and an important predictor of myocardial disease and mortality. And with that, I thank you very much for sitting with me. And as always, if you have questions, please feel free to send me an email or a message.